My name is Robert Rhee. I'm the chief of vascular surgery at Maimonides Medical Center in Brooklyn, New York. Well, the story began more than 10 years ago, um, actually 15 years ago, when W.L. Gore decided to pursue their next generation of the very successful excluder infrarenal AAA device. They called in consultants and asked them what their needs were based on what patients they were unable to treat with the current devices available. And through consultation of various vascular surgeons from throughout the world, several key factors were identified, namely the ability to maximize the infrarenal sealing zone. In order to do that, we need to be able to readjust the device so that we get maximal sealing. And that was a major consideration. The second consideration was that we needed to have a device that is specifically designed for sealing in this type of a region. I mean, this is the minimal seal zone. So other devices were not developed in such fashion prior to this conformable excluder device. So we asked that the device be specifically engineered and tested for the infrarenal sealing conditions that we all wanted, with namely sealing zone of 10 millimeters minimum. That means, be able to seal at 12 and 13 millimeters, as well as be able to flex enough to accommodate infrarenal neck angles up to 90 degrees. So this device was developed with that and with those two key features in mind. And the background of the device was really born out of physician need. And it was an unmet need that the company responded to. The study design was a prospective IDE trial. It was a FDA-approved trial, which involved two subsets or two arms. The first arm being the short neck arm, which allowed up to 60-degree angulation and up to 10 millimeters of neck seal. So that arm had 80 patients in the trial, and the other arm was the high-risk arm, which was the high angulated neck angle, which is greater than 60 and less than 90. So this was a slightly larger group of 95 patients which were enrolled. So the company was very specific in its intent to test this device out in hostile neck situations, or not necessarily for this device, but for the previous devices. The key findings were that when you break down all the groups, we now have 5-year results for both arms of the study. And, the ultimate result was that the patients with very short necks between 15 and 10 millimeter necks, as well as the high angulated necks in the 60 to 90 degree range, did extremely well, and did as well as the standard necks, the necks that were 2-3 centimeters in length, or the angles that were less than 60. So the conclusion of the study was that this device was able to treat the intended target, which target patient population, which was the 10 millimeter seal and up to 90-degree angulation, with no other or more untoward events or complications related to treating these high-risk necks. So both arms of the studies showed amazing effectiveness, as well as long-term 5-year outcomes, which was equivalent or better than most EVAR devices out there. The major take-home message is that now that this device is available throughout the world, vascular specialists are now able to treat these high-risk necks. And more importantly, many of the trials which involved devices which were relatively capable, the problem was the ability to get the maximum seal zone. For example, if the neck was 13 millimeters. Actually, because of the deployment, the seal zone was only 8 millimeters. So some of the poor results from some of the high-risk neck publications are most likely due to malpositioning of the device at the initial implantation. So this device will enable the user to really get the maximum seal zone that is possible. So I believe that this device will be a game changer in that respect and will allow us to treat more patients with high angulated necks as well as relatively short necks. The patients who are in this high risk neck category generally tend to be treated with fenestrated devices. So I think many of those patients can be treated with this device with excellent long-term results, as evidenced by the 2 subset trial publications. I believe that doing a fenestrated procedure is more extensive and requires more expertise. So many of these patients can also be treated outside of the specialized centers, which is overall good for the patient and good for follow-up compliance.